our webinar hosted by the Islamic Medical Association in coordination in conjunction with the South African Renal Society and the African Society of Nephrology. And we're very happy to host this webinar together. As most of you know, I have roles in both these organizations, all these organizations. The other, just from the South African Renal Society side, this is part of our collaborative effort over the year to have joint webinars with several different societies. Our next one planned is potentially in association with the South African Endocrine and Metabolic Society on diabetes and chronic kidney disease, given the changes and the multiple advances in that area. And then also potentially later in the year with the South African Rheumatology Association, if we can get them on board to look at a joint webinar on lupus and the kidney. So I think that's from the SA nephrology side. From the Islamic Medical Association of this side, these Webimas or Web IMAs have become a feature since COVID, and alhamdulillah, they've been very well attended, and the reception has been excellent. So this is part of a series of those webinars, and we plan to have several of the year. So please look out for messages from Kashifa or from on the IMA groups for the webinars that are planned. I think there are already a couple in the pipeline. So without further ado, as I mentioned, just from a housekeeping side, if people could keep their cameras off so that it uses less bandwidth, and obviously it makes it easier for everybody else. The speaker is welcome to keep his camera on or off, but maybe when we do question time, we'll ask him to keep it on. The plan will be to go through each talk and then to have a question and answer session after that. If you could please put your questions into the chat. Alternatively, raise your hand once the talk is over, and we will give you an opportunity to take questions. We do have enough time, I think, for questions. So our first speaker is Dr. Zakaria Gangat. Zakaria is a specialist physician and nephrologist. He's been working with me at the Wits Donald Gordon's Medical Center for the past 10 years, and at the Glenwood Hospital in Benoni. He's an experienced nephrologist in private practice. And I think all the speakers will bear testament to the fact that we get asked these questions by our patients all the time: is, can I fast or should I fast? And we know that many of our patients will fast regardless of what we tell them. So we thought it's an opportune time to look at what the evidence is and what details we have available in terms of the safety and the permissibility and ability of patients with chronic kidney disease and other areas in nephrology to fast. So welcome, Zach.
Thank you, Shoaib, and thanks for the invite from both the IMA and SANS. Assalamu alaikum and good day to all. Many of you would have otherwise been trolling the malls for last-minute Eid prep. So for those of you that chose to spend your Saturday on this webinar, I hope we make it worthwhile. I'll be talking today on chronic kidney disease and fasting. So let's go through it. As an introduction, we know that chronic kidney disease is widely prevalent among Muslim patients. Patients are keen on fasting. It's seen as an honorable act and a virtuous deed. But prolonged periods of fasting may not necessarily be beneficial to certain population groups. There's a lack of data in guiding clinicians as to what appropriate advice to patients are. And many of us would have had our opinions sought by patients, as Shoaib has said, in terms of whether it's appropriate for them to fast. That being said, there's still a requirement for greater research into this area. In terms of the epidemiology of CKD, there's been an exponential rise over the past few decades in terms of diabetes, hypertension, and cardiovascular disease in your Middle Eastern, North African, and Muslim majority countries. As noted, similarly high prevalences are seen in Pakistan, Bangladesh, and other Asian countries. Coupled with this rise in non-communicable diseases, there's been a rise in the prevalence of chronic kidney disease and end-stage renal failure. It accounts for a significant proportion of the budget, And prevalence rates from population-based studies vary from between 5 and 20%. In terms of fasting in Ramadan, there are approximately 1.8 billion Muslims globally. Fasting is made compulsory for Muslims post-puberty, and the fast is observed during the lunar month of Ramadan. Now, the lunar month itself covers 355 days rather than 365 as in the Gregorian calendar. And the month of Ramadan comes forward or is earlier by 10 to 11 days each year. So over a 33-year period, it tends to cycle across all seasons. The importance in that is it results in variations of the length of the fast. So in your equatorial regions, you've got an average fast length of between 12 and 14 hours. In SA, probably up to around 15 hours in the summer month. But in areas of higher latitude, your Nordic countries, Northern Europe and the like, you do have fasts that vary from being up to 20 hours within the winter months, right through to a fairly short fast of around 8 hours, or 20 hours in the summer months, right up to a short fast of around 8 hours in the winter. Muslims are encouraged to partake in a pre-dawn meal of sehri or suhoor, and in the post-sunset meal of iftar. In terms of exemptions, Islam allows and makes clear exemptions for prepubertal children, pregnant or breastfeeding women during their monthly cycle, those with severe frailty, and those with certain medical conditions, which includes chronic kidney disease. There's a clear medical dispensation given to those in whom the fast is considered harmful to their health. Despite the above, many high-risk patients continue to fast either for personal reasons or because they're unaware of the risks to themselves. Patients require guidance and clear instruction with regards to fasting and rules in terminating a fast should the risk be high. For those non-nephrologists that are on the group, just a brief classification of chronic kidney disease. CKD is categorized, or chronic kidney disease is categorized by two things, namely the protein, or rather the protein leakage or albuminuria, and more importantly, the glomerular filtration rate or GFR. And it's anywhere from patients with normal GFRs of more than 90 right through to those of less than 15, which fall into stage 5. The bulk of the patients managed by nephrologists within our practice tend to be from stage 3B onwards. So patients where their filtration rates are sitting at under 45. Of note is that in chronic kidney disease, it's not necessarily just this, but chronic kidney disease may also be defined by anatomic abnormalities in patients with polycystic, in patients with histological abnormalities, or as said, urinary abnormalities. Now, in terms of the guidelines for fasting in Ramadan, unfortunately, there aren't any national or international guidelines that exist specific to fasting and CKD. There have been a few authors that over the past decade have made efforts in terms of drafting guidelines, namely Bragazi in 2014. Ahmed and Chaudhry in 2019 looked at the data once again, and as recent as 2021 and even 2022, there have been authors that have looked at and the data with respect to fasting and chronic kidney disease. Our endocrine colleagues are ahead of us in this, and they've got diabetic guidelines specific to fasting, and within these guidelines, it incorporates diabetics with chronic kidney disease. And I'll try to unpack some of that. So there's the International Diabetes Federation Fasting and Ramadan International Alliance was a working group that invited experts in their field. There was a review of the latest and the most relevant studies. And in areas where data was missing, expert opinion was sought. The guidelines are comprehensive. in that they cover most categories of diabetic patients, and they include diabetics with chronic kidney disease. It's endorsed by many religious authorities. Most notably, it was taken up, it was endorsed by the Grand Mufti, or the scholar in jurisprudence in Egypt, and many other countries have followed suit. And importantly, diabetic patients account for a substantial portion of our chronic kidney disease population, with up to 50% of our end-stage patients being diabetic. We are able to use these guidelines and the data in formulating it in guiding our patients with diabetes. What was noted in the data that they looked at was that there is definitely altered physiology during fasting. Now, in addition to the fast, during the month of Ramadan, there are evening prayers. There's a requirement for waking early for the pre-dawn meal. And many patients find themselves having sleep deprivation as a consequence of it. Associated with this, there's some degree of glucose intolerance and insulin resistance. In many Arab countries, together with North Africa, you tend to find that patients are very active during the month of Ramadan in the evening hours, and often tend to take breaks or rest during the day. This would result in a shift in the cortisol circadian rhythm. In diabetic patients as well, during patients that are fasting, there's increased glycogenolysis, gluconeogenesis, and ketogenesis, or metabolism or conversion of fatty acids to usable substrates. Now, what was noted, there was a population-based study called EPIDIA, which was a study in the early 2000s that looked at diabetes and its characteristics during Ramadan in 13 different countries. And what they noted in the study was that there was a 4.7 to 7.5% greater risk of hypoglycemia and a 5 times greater risk for hyperglycemia. Now, noting that these are complications or issues that are seen in diabetic patients, within healthy individuals, there are favorable physiological responses in fasting patients, including improvements in their lipid profile, a drop in their weight, and BMI. Just this is a table that's been adapted from the guidelines that were provided. And importantly, patients were risk stratified according to their risk into three categories: a moderate or low risk group that were allowed to fast provided they listened to medical advice. There's a high risk group that should not fast, but should they choose to fast, there is advice for them and an education plan for them. And then you've got the very high risk group that were told categorically that they should not fast, or must not fast rather. Now, within this group, we do have our chronic kidney disease patients. So patients with chronic dialysis, on chronic dialysis, or your CKD stage 4 and 5 patients who are categorized as very high risk. Your stable stage 3 CKD patients were in the high risk category. Remember, we're talking about chronic kidney disease in this, these are risk categories in the context of the patient being diabetic and with CKD. With regard to the guidelines, just to go through that once again, the principal risks in fasting are the risk of hyperglycemia, hypoglycemia, the severe complication of diabetic ketoacidosis, dehydration, and thrombosis. So stable CKD patients were allowed to fast following guidance. As noted, CKD 4-5 and your dialysis patients should not fast. The category of CKD 3 with pre-existing cardiovascular disease was seen separate from stable CKD patients, and these patients were considered at a higher risk than your stable patients. Patients with known electrolyte abnormalities, especially hyperkalemia, were considered high risk. And there were certain drugs that are in common use for these patients that put them at a higher risk, namely your ACE inhibitors, your ARBs, your newer SGLT2 inhibitors. And in patients that are keen on fasting despite, consideration should be made to adjusting the medication for these patients. This is a very busy slide, and what I want to do is it talks about the various studies that are in your non-dialysis chronic kidney disease patients. They're fairly busy. It's a fairly busy slide, and what you'll note just briefly by looking at it is that the number of patients enrolled in each of these studies are minimal. With regard CKD non-dialysis, I just want to briefly discuss some of the more relevant studies from that group. There was a Saudi Arabian prospective cohort study that enrolled stable CKD 4 and 5 patients. Low potassium and fluid restriction were advised. Medication was adjusted in the month prior to Ramadan to include daily diuretics and in some cases, exchange of your ARBs or ACE inhibitors for less risky drugs. Patients with a history of hyperkalemia or that were thought to be at risk were offered sodium polystyrene sulfonate or Kxalate as we popularly know it. In this group, there wasn't any significant change in hypertension, in their metabolic parameters, in terms of their filtration rates or weight. 20% of these patients had lower lymphedema that was considered mild. In terms of your non-dialysis studies, the other ones that were important was there was a UK observational study done by Chowdhury in earlier stages of CKD, so CKD 2 and 3. And this was done in the UK at the time that the fast being observed was 19 hours in length. And there wasn't any difference between the fasting and the non-fasting group. Nasrullah and Osman looked at cardiovascular outcomes in your CKD stage 3 to 5 patients, and patients with a history of major adverse cardiovascular events were noted to be at risk of further events. When you're talking about major adverse cardiovascular events, they refer to patients having had strokes, patients where peripheral vascular disease had worsened and there was a need for an intervention, patient who had a myocardial infarction or MI during the course of the month, or patients who presented with worsening of heart failure. What was noted in the study was that the serum creatinine jumped in a number of patients by day 7. A number of these patients were using RAS inhibitors, including ACE, ARBs, together with the MRAs. And there were 6 events in the fasting group compared to 1 event in the non-fasting group. The reason, or it was postulated that the reason behind why these patients had events was following fast initiation, there was some degree of mild dehydration, and following on that, there was thrombosis or hyperviscosity and thrombosis that followed. Just briefly summarizing the remainder of the studies in your non-dialysis CKD patients. The majority of these studies don't show significant changes for GFR, for blood pressure, for BMI, or biomarkers of injury. The outcomes vary in your smaller studies, some showing a sustained decline in GFR, others showing an improvement in your creatinine clearance associated with a reduction in weight during Ramadan. AKI criteria were met for a few. AKI criteria meaning that over and above the background of their chronic kidney disease, there was some evidence to suggest an acute insult or acute kidney injury. There were a few studies that looked at subjective markers where changes in or measures of fatigue, mood, and cognition were looked at. Importantly, what we see is that there's great heterogeneity between studies, between the baseline of our patients in terms of the number of days fasted, the fast duration, and the length of follow-up. This is a table that looks more specifically at the patients, or rather that looks at patients, published studies on hemodialysis patients. And once again, I'll just try and unpack for you what the more important studies are. There was a Saudi Arabian study that enrolled 635 patients, so fairly large in this study. It was a multi-center study. Parameters were measured prior to Ramadan and during Ramadan. They looked at interdialytic weight gain. And once again, for our non-nephrologists, what interdialytic weight gain refers to is the weight gain between one dialysis session and the next. And in most cases, when looking at interdialytic weight gain, it's assumed that the weight gain between dialysis session is attributable to fluid gain. They looked at blood pressures, pre and post hemodialysis. They looked at the potassium, the phosphate, and albumin levels. Albumin giving an idea as to the nutritional status. They looked at hypotensive episodes. So in patients on dialysis, should they encounter a drop in blood pressure, we would often infuse saline. So they looked at the number of hypotensive episodes that were encountered and the need for saline infusions over this month. And what was picked up was that there wasn't any significant difference in dialysis or biochemical parameters. That being noted, it doesn't, the one major criticism of the study was that we weren't comparing apples with apples. The fasting group were younger, they were more likely to be employed, they were more likely to skip sessions, and by virtue of being younger, were probably healthier at baseline. There was a higher phosphate level picked up on your fasting group. There was a Malaysian study that looked at patients fasting for greater than 20 days. And in this group of study, there was a decrease in BMI and markers of obesity over the course of the month. These patients seemed to be very compliant in that there was reduced interdialytic weight gain and an improved phosphate, urea, and creatinine. There was some positive benefit to fasting in this group in that they had an improved hand grip strength post-Ramadan. The criticism with this study was that the timing of the measurements in terms of your laboratory markers was unknown. Once again, in patients where we would routinely check on lab results or lab tests in the month or just prior to the next dialysis session. If we do lab tests shortly after a dialysis session, you will find an erroneously low phosphate, you will find an erroneously low potassium, urea, and creatinine. So timing is critically important within these patients. The authors concluded that dialysis posed non-detrimental nutritional, or rather fasting posed non-detrimental nutritional risk for patients on maintenance dialysis. Other study outcomes, there were reports of increased interdialytic weight gain among some studies. There were increased levels of potassium and phosphate in some patients. Hyponatremia was noted in a few. Albumin levels were very variable. There was one analysis done in Pakistan in a single center in Karachi, observing patients over a 20-year period. And what this showed was there was an increased mortality in Ramadan. They weren't able to give data in terms of whether the patients had fasted or not, whether there were any other issues experienced during the month of Ramadan, but this was the one bit of info that came through from that study or from that analysis. So I don't think we can draw too much into it. In terms of peritoneal dialysis, there's only one study available. Al-Wakil and colleagues in Riyadh studied 31 PD patients. Modifications were made to the dialysis prescriptions to include extra cycles at night, and complications in this group of patients numbered less than 25%. There weren't any major morbidity or mortality complications. The complications that were encountered were considered minor. Small PD-related pleural effusions, mild fluid overload, and there was one case of peritonitis, although that doesn't seem to be related to fasting. So I just want to go through the discussion on the current data. So I've showed you, up to this point, I've showed you the studies that looked at patients in your dialysis group and your CKD groups. But in going through the discussion, there's a few things to note. The first is there's a lack of robust, high-quality data. Most of these studies are observational and prone to selection bias. We're dealing with small sample sizes, and in dealing with small sample sizes, it's difficult for us to be able to achieve statistical significance in drawing conclusions. The patients enrolled were younger, they were motivated and willing to heed advice. The studies were done predominantly within Middle East and North Africa, with fast durations of approximately 12 to 14 hours, with reduced working hours. So what often happens within these countries is allowances are made for reduction to working hours during the month of Ramadan. In our context, most patients continue fulfilling a full day's work during the month of Ramadan, and the findings are not generalizable. Religious considerations. As a general rule, any form of nutrition that passes a mucosal route, oral, nasal, and rectal, invalidates a fast. Topical, intramuscular, and subcutaneous forms of administration are acceptable. With regard to permissibility of hemodialysis, there have been various religious edicts that state that fasting is not invalidated by hemodialysis because it's not done through a mucosal route, although the contemporary scholarly opinion opposes this idea. For patients on PD, adjustments to scheduling can allow for the treatment between sunset and sunrise. Islam permits and supports those with appropriate ailments to be exempt from fasting, and any condition that through fasting can adversely affect a patient's health falls within this category, and this includes chronic kidney disease. Allowances are made for conditions where fasting would result in deterioration or decompensation of chronic stable conditions. There are alternatives to fasting. So patients are able to make up for the missed fast when health permits them to do so, or when the acute condition has passed for other ailments. In the context of chronic kidney disease, when fasting may be better tolerated. So in countries where there's a incredibly long summer fast, but the winter fasts are short duration, they may consider fasting during this time. There's also the option of fidya, which is a requirement to feed the poor in those that are unable to fast for patients that have the means to do so. When we're looking at our patients, we've got to have an individualized approach. The patients we encounter in practice vary widely, and a number of factors would guide our decision. The stability of the patient is important, and we know of patients of ours that are very stable and very compliant, both with diet, fluids, and the like. And we have many patients that unfortunately are never going to be able to heed or stick to certain restrictions. So compliance with fluid restriction is an important factor as well. Patients that have residual renal function, and what we mean by this is that patients in whom their kidneys still perform some function and dialysis is performed in addition, these patients may do better compared to patients where there's complete dependence on dialysis because they've got zero function, zero kidney function of their own. Current medication needs to be reviewed in patients, specifically, as stated earlier, ACE inhibitors, your ARBs and SGLT2 inhibitors. Electrolyte levels need to be looked at, specifically what patients' current levels or what their level of control has been with regard to potassium, sodium, and phosphate. We've got to look at patients' nutritional states and the degree of sarcopenia. The average age of patients on dialysis within our setting is probably between about 55 and 60. And many of them are already nutritionally deficient with poor muscle bulk and being underweight. And fasting in this instance may not aid them. It may worsen their sarcopenia. And access to appropriate healthcare is important. Within the bigger cities and major centers, patients do have access to us, and especially with your dialysis patients, these patients are seen on a weekly basis. That may not hold true for smaller centers and patients in rural areas or cross-border where access to appropriate healthcare should a complication arise is not always available. There are other factors that we need to look at in terms of the average ambient temperature, so your general weather conditions, so hotter climates where there's greater insensible losses and greater losses through sweating may often lead to dehydration. We've got to look at the duration of the fast in terms of whether it's a short, manageable fast or whether it's exceedingly long. We've got to take into account the patient in terms of the type of work they do, whether they're physical or manual laborers, because these patients often have a far greater requirement for fluid intake. And as noted, the working hours, standard working hours versus reduced working hours offered to some patients in Ramadan. In terms of the guidelines, fasting should be discouraged amongst patients with chronic kidney disease, CKD, to 3 to 5 with pre-existing cardiovascular disease. And your data supports that. In your CKD 4 and 5 patients, in hemodialysis and PD patients, in patients where electrolyte abnormalities put them at risk, specifically potassium, in those at risk of dehydration. Stable CKD 1 to 3 patients, stone formers, and patients with recurrent UTIs can fast, provided they adhere to guidelines and maintain fluid intake during the non-fasting period. As said, adequate fluid intake during the non-fasting period is important, depending on your fluid status, obviously. Daily weight measurements at the end of the fast should be done by patients that are choosing to fast to ensure that they've got adequate hydration. In patients that choose to fast, it would be important for us to check on their laboratory markers about a week into the month of Ramadan, monitoring for a creat bump. So should we find that there's worsening of their metabolic parameters, that we can strongly advise or discourage fasting for the remainder of the month. But these patients would have benefited from having a trial, and I think they'd be appeased by that. We need to monitor for weight gain, edema, dyspnea, anorexia, and lethargy. And as noted, avoidance of high potassium and phosphate foods at iftar. This makes it difficult given that many patients are keen on following kajur or following the recommendations of breaking your fast with kajur. And many patients often indulge in your high phosphate dairy drinks and milkshakes in the evening. There is Malik and group tried to create a decision-making pathway for patients that wish to fast during the month of Ramadan, in terms of exploring the patient's own wishes and trying to risk stratify these patients. Patients that are considered high risk or very high risk to explore alternative option, and should patients choose to fast, to still educate them and provide them with plans should things not go according to plan. So you'd want to counsel them about the risk of fluid overload, electrolyte abnormalities, and nutrition requirements. You'd want to make necessary changes to their medication. You'd make adjustments to the dialysis times and advise them to terminate the fast if they become unwell. The trial fast in the month prior to Ramadan, I think, is a good idea in patients that are determined to fast. For PD patients, they created Malik and colleagues once again try to create a pathway or a decision-making pathway. And in this group here, there was the option, some patients had sufficient residual function to consider the temporary option of holding PD. We're not in favor of this, or the nighttime exchanges as noted previously. In conclusion, fasting or Ramadan is an important month within the Islamic calendar, and fasting is considered an important act in one's devotion to faith. Our advice is often sought, and we should be giving our decision the necessary attention. The discussion needs to take place in the month prior to Ramadan, rather than during the month of Ramadan, so that appropriate time can be given to making adjustments to patients' medication should that be required, and discussing the pros and cons. We need to risk stratify our patients and advise against fasting where the risk is high or very high. To those that choose to fast despite, we need to monitor and provide guidance to those. These conversations need to be patient-centric, and often our role is to aid decisions rather than making decisions for patients. The aim ultimately for all of us, both practitioners and patients, is to have a safer Ramadan experience. Thank you. Shoaib, back to you.
Thanks, Zach. Thanks for that. So I think we've got some questions on the chat already. So I mean, maybe we can start with those, Zach, and then people can raise their hands and we can see if there's any other questions that people want to ask. So Dr. Yazid Chotia has asked, in dialysis patients during the procedure, if glucose diffuses into the bloodstream, does this not invalidate the fast?
So there's a huge difference of opinion. As said, as long as it's not passing through a mucosal route, it's considered to be valid. But I think different authorities have differing opinions on that. The more contemporary scholarly opinion is that hemodialysis would invalidate a fast.
So as Zach says, the majority opinion for decades and in the past has always been that as long as food is not entering the oral or rectal route, that it's permissible. For example, so injections, subcutaneous injections and medication infusions and so forth were not really considered to invalidate the fast. I mean, Yazid raises a point, obviously during dialysis sessions, there's movement of fluids and different electrolytes between the dialysate and the patient's bloodstream. And then obviously that includes glucose. One of the sort of minority opinions in the past is that if somebody deliberately takes something which has nutritional value, it would invalidate the fast. And I think this comes down to the intention that the person has. So, you know, if you look at the spirit of the Sharia or the maqasid of the Sharia, the idea of fasting is obviously you're not trying to trick God. You know, you're trying to do it to achieve closeness to God. And I think the intention in these patients with dialysis is obviously vastly different. They're not trying to trick God by taking nutrition during dialysis. It's an eventual consequence of the treatment. So my opinion and the opinion of many is that it does not invalidate the fast. However, so I do explain this to patients, and then those who are able to fast during dialysis, and there are some, but I tell them that if there's any doubt, then those 12 days of dialysis that they're doing during Ramadan, they shouldn't fast, and they can make those fasts up on the other days. So I mean, that's an option open to patients. If they have doubt that their fast is valid, then they can make those fasts up on another day after Ramadan, when they're not on dialysis. As you know, we don't dialyze every day.
Yeah.
The next question is by Dr. Farhad Mohammed. The effect of the fast on the kidney. So Zach, I think you didn't touch a lot on that, but maybe we can talk a bit about that. And I think there are many other experienced nephrologists on the call. If anybody wants to comment on that, they can raise their hands as well. Zach?
So in terms of the effect of the fast on the kidney, I mean, in patients that are healthy and otherwise well, an 8-hour fast would be easily managed. The kidney has got the ability to concentrate urine and deal with mild degrees of dehydration, in a sense, where there are mechanisms in place to reduce the amount of urine output together with preserving salt and water. So I think an 8-hour fast should be easily tolerated. That being said, like you know, from the look of it, if we're talking about patients with chronic kidney disease, you know, the kidney is somewhat compromised in this instance. And in those patients, what we're trying to work out is whether or not there is safety. An 8-hour fast for a patient with CKD 4-5, where they've got other issues already, may be deleterious. And I mean, from the data, it seems as though the conclusion was that in these patients with advanced kidney disease, that they may not tolerate the fast altogether. And there are alternatives to fasting in these patients. For a healthy patient, it's not an issue.
Yeah, I think that's an excellent answer. And as Zach alluded to in his talk, I mean, when you're making this individualized decision, you're going to look at the factors around the decision. So obviously the patient-related factors, how severe the chronic kidney disease is, and in the more advanced stage of chronic kidney disease, some patients may be on the cusp of dialysis, and we know in these patients, small things can really push them over the edge, and you really want to be really careful before you allow patients like that to fast. Patients who are very prone to variations in their kidney function with small levels of dehydration or have recurrent infections and drop their renal function and those type of things. So I think you really need to individualize this decision. But I think for the majority of patients with earlier stages, maybe up to stage 3, a shorter fast is fine. And then obviously the medication, as Zach has said many times, you need to change the medication. If they're on diuretics like twice a day, you may need to reduce the diuretics or change when you take it. And then obviously the fast related factors, how long is the fast, how hot is the temperature where you are. So those things will all have an impact, because I suppose if you're fasting in Equatorial Guinea during the middle of the day, it's quite humid and hot, and you're fasting for like 12-14 hours, you could seriously be at risk of dehydration, especially if you're working in an environment which is warm. So I think those are the type of things. So there's not a blanket answer, as like I said.
Yeah, no. So I think there is a blanket answer. I think, as I said, when I looked at the data, and when I looked at the literature reviews for guys that have looked at the data, I think the big thing is we shouldn't be encouraging patients with CKD4 and 5 to fast. We should note that there are risks there, and if these patients choose to fast despite being aware of the risk, then you advise them in certain ways. But I think it looks as though there may be harm to some of these groups.
So Dr. Shibnam Adam has asked, is alternate days an option to fast?
I think it may be a safer option than daily, but for patients that choose to fast despite, it may be a safer option to go alternate day as opposed to fasting daily. Especially for those that are sarcopenic, in those that lack muscle bulk, in those where their nutritional state is not optimum. Once again, I wouldn't be encouraging this, but should your patients be insistent and they're going to fast despite, if you put this option forward to them and they agreeable, it may be safer than daily for your patients with CKD.
Yeah, I mean, I think the important thing to remember is that there is leave given, from the religious side for patients who are sick. The Quran is clear on that if you are ill or on a journey, you can make it up later if you recover, and if you're not able to recover, then obviously you feed poor people. And so I think it's about engaging the patient, and many patients are desperate to fast because they fasted their entire life, but I think it's about engaging them about the risks in their individual case. I mean, Farad has asked, is there any literature to the effect? And as Zach has pointed out, I mean, the literature is limited because patients vary so much. But from what he has shown is that patients with more severe and advanced disease in terms of chronic kidney disease are at much higher risk. So maybe those stage 4 and 5, we should really be very, very careful before we recommend that they fast. Any other questions? Are there any hands up? We have like maybe another 2 minutes. Okay, so there's no further questions. We'll go on to our next speaker. So I'd like to welcome Dr. Zahir Laher. Zach, maybe you can stop sharing and Zahir can share. So Zahir is going to shift a little bit and look at an area of nephrology, which is a bit different to patients with chronic kidney disease on its own, and look at transplantation. And Zahir completed his undergraduate medical training at the University of Pretoria, and he completed his medicine and nephrology training at WITS. And then he has been a recipient of the International Society of Nephrology Fellowship, and worked for some time in San Diego under the guidance of Professor Mita. He's currently in private practice in the Midstream Mediclinic and Netcare Garden City in Gauteng. And his passion remains critical care nephrology and cardio-renal medicine. He's an amateur barista and loves his coffee. So for all those who know Zahir, you know how much he loves his Lamazoko coffee machine. So we can move on to there and welcome him. Assalamu alaikum and welcome, Zahir.
Jazakallah khair. Thank you, Shoaib, for the welcome. I'd like to thank the Islamic Medical Association and the South African Nephrology Society for the opportunity of presenting on this topic, which frequently poses a challenge to the treating nephrologist as well as the transplant patient. The aim of this talk is to give a practical framework to approach Ramadan in patients with kidney or organ transplants. Ramadan is the most sacred month of the Islamic calendar. During this month, the first verses of the Quran were revealed. It reminds us of our frailty and dependency to the Almighty and allows us to empathize with the socially deprived members of our society. And for some of us, it's the only opportunity with a world full of excess to actually experience hunger and deprivation. It's an obligation for healthy individuals. There are exemptions, as mentioned earlier, for prepubertal, women during menstrual periods, pregnancy, during a breastfeeding period, the elderly and frail, travelers, mentally disabled, and the sick where fasting may aggravate their mental condition. By far the most superior form of renal replacement therapy is a kidney transplant. It allows for an improvement in quality of life with markedly improved survivals and fewer episodes of hospitalizations. There's also fewer restrictions in terms of travel, in terms of fluid intake, in terms of dietary restrictions as well. And for many patients, it's also, after many difficult years on dialysis, there's a burst of optimism about the future. And it may feel for patients to give them an opportunity to fulfill religious obligations. Exemptions for fasting for solid organ recipients are absolutely consistent with Islamic jurisprudence. However, many of our patients still have a deep desire to fast. And the aim is to give a practical framework to risk assess. And again, as Zach mentioned earlier, there's a lot of seasonal and geographic locations which play a part. With the kidney transplant, the same things allude to with the CKD patients, that most of the studies have been performed in the Middle East and North Africa, where there are changes made in terms of lifestyle and limitation of work hours and a more nocturnal life. And there's very little studies performed in the long Northern Hemisphere summers. And as Zach mentioned, in a 33-year cycle, we expect to go through all 4 seasons. The average duration in Johannesburg of fast ranges between 12 and 15 hours during the various seasons. So similarly to patients with CKD, we perform a risk stratifications. We break patients into very high-risk patients, and moderate to low-risk patients. Very high-risk patients, these patients should be actively encouraged not to fast, as fasting will issue a very significant risk to their graft or also to their life. Solid organ recipient transplants who underwent a transplant in the last 12 months, patients on twice daily formulations of immunosuppressions, pregnant transplant patients diagnosed with post-transplant diabetes mellitus requiring twice daily oral hypoglycemics or insulin treatment, kidney transplant patients with reduced kidney function of less than 30 milliliters per minute, and patients with unstable graft function, recent rejection episodes, or opportunistic infections, and patients with moderate to severe frailty. As again, they should be actively discouraged, and there should be an emphasis that harm could occur during this period. Similarly, the high-risk patients should also be discouraged to fast. These include patients with kidney transplant recipients with a graft function of between 30 and 60 milliliters per minute, heart, lung, liver, and small bowel, pancreas, and multi-organ recipients with reduced graft functions, and patients at risk of dehydration due to the need for fluids restriction, need for diuretics, or if they were unable to meet their daily fluid intake requirements. These also include patients like with recurrent stone formation, which could be negatively impacting on their graft function. The cardiorenal patients where managing of fluid status is particularly challenging, where there's a small difference between overhydration and underhydration of patients. The last group of patients are the moderate to low risk patients. These are transplant patients not in the above categories. We would advise patients to discuss the suitability of fasting and monitoring necessary with their relevant transplant teams, and they should follow medical advice. Again, there's always a degree of risk associated with, with fasting, regardless of the transplant status. I found this to be a very helpful algorithm. So the first thing we should discuss is what does the patient intend to do? If the patient does not intend to fast, it's easy. Patients should continue with their current treatment. Excuse me. And if patients do intend fasting, they should explore the patient's wishes for Ramadan, what sort of work and other responsibilities are available, and patients should be risk stratified. Patients should be risk stratified, as mentioned earlier, between very high risk and high risk patients. These should explore alternate options, such as paying fidyat or fasting during the period of the winter solstice. If patients still choose to fast, the following should be emphasized. We should educate the patient on the risks and reinforce sick day rules. Patients should be counseled about the risk of fluid imbalances, electrolyte abnormalities, nutritional requirements, and fluid intakes. We should be making necessary changes to immunosuppression more than a month before Ramadan, and we should start exploring once daily alternatives. We should monitor graft functions, electrolytes, trough levels, and cyclosporal levels during Ramadan. And we should advise patients to terminate fast if they become unwell. And again, considering trial fasts for fasting for a few days prior to the month of Ramadan. Again, there's a paucity of data on patients, and most of the data is coming out of the Middle East and North Africa, and excludes the long Northern Hemisphere summers, and all the studies are done in a particular context. This was a meta-analysis that was done by Bin Sila et al. And again, there's significant concerns about the quality of data that we're making decisions on. There were significant confounders. There wasn't enough expression about immunological risks. There wasn't enough discussion with regards to immune suppression, rejection episodes, and there was a publication bias. The patients who did fast were determined to fast. And again, the emphasis is on nearly all the patients that were studied had a GFR of greater than 60 milliliters per minute. The conclusion that was made that Ramadan did not significantly affect kidney function or blood pressure in post-transplant patients. Patients were utilized using themselves as their own controls. But again, the emphasis is on patients with good graft functions. We have no data on patients with lower graft function of less than 60 milliliters per minute. The blood pressure, also there was no significant changes in transplant parameters before and after Ramadan. So ideally, this should not be rushed if patients have a strong intention to fast. Medication changes can have significant impacts on graft function. We have daily tacrolimus formulations. Advocraft is the commercial name. This should be introduced significantly before any decisions are made before transplantation. Some of the mTOR inhibitors are also valid options, but again should be made in the context of immunological status and other comorbidities. These are also once daily medications. As a press, is also an option instead of CellSap or mycophenolate, and can be considered in patients with a low immunological risk of, and this is again a very cautious and considered decision that needs to be made. CellSap or MMF is a more forgiving drug in our context of approximately 13-hour fast, and it would not be unreasonable to take MMF at fixed periods during Sehri and Iftar. Patients need to be extensively counseled. Patients need to be understood that a kidney donation is a special gift. It is an amanat and it is a trust on the patients. And we have a moral obligation to care for the graft and failure to care for the graft and to protect the graft, as failure of the graft will have an important impact on the ability for the individual to perform prayers, as well as greatly inconvenience the family and the support structures. There are alternatives, as discussed, to keep fast close to the winter solstice and to pay fidya. I think fidya ranges between 11 and about 30 rands, and the intention is to feed a person of need. The emphasis during the month of Ramadan is on mercy and compassion, and the patient should feel mercy and compassion to their own well-being as well. Patients should be have their fluid status monitored very closely and should be counseled on the risk of dehydration, acute kidney injury. There should be a daily weight and blood pressure monitoring performed, and a judicious review of blood pressure medications and diuretics. The important medications is the dosing of the diuretics. Very often we require less diuretics. Twice daily diuretics are normally reduced to daily. Doses of SGLT2 inhibitors are decreased or stopped, and the angiotensin receptor blockers, the ACE inhibitors, and your mineralocorticoid agents should also be carefully reviewed previously. Patients should also not feel obligated to keep all fasts continuously. There was a mention during the chat conversation about alternate day fasting, and I think that's a reasonable option to not feel pressurized to fast continuously. Dehydration or a feeling of being unwell, patients should have a very low threshold to break their fast. Patients should log their intake and outputs, and they should reinforce sick day rules and be aware of their status and how they feel, and should stop fasting or not start fasting if they're not feeling well. There should be regular blood testing during the month of Ramadan. I do not think it's unreasonable to be checking blood tests every 7 to 10 days. The blood tests which I think are important are your tacrolimus trough levels, your UNE, and your urinary protein creatinine ratios. It's a good opportunity when discussing fasting is to broadly talk about dietary guidelines. Dietary guidelines are particularly important in transplant patients. Transplant medications may place an additional metabolic burden on individuals. And remembering, patients who required transplants had significant comorbidities, which may have resulted in end-stage renal disease to begin with. Low salt and adequate hydration are absolutely crucial. To maintain a healthy lifestyle post-transplant, patients should be educated about the scientific evidence of different diets and to choose a dietary pattern which is sustainable in the long term. Lifestyle interventions are a crucial part of looking after kidney graft, and healthy lifestyle choices as well as exercise have a far greater impact than any individual medication with a significantly lower costs. The 3 diets that need to be considered for patients are plant-based diets, Mediterranean diets, and the DASH diet, or the dietary approach to stop hypertension. Plant-based dietary patterns is primarily composed of whole grains, fruits, vegetables, legumes, nuts, and seeds. Animal foods such as meat, poultry, fish, eggs, and dairy are typically consumed in small amounts or excluded entirely, making these diets lower in animal protein than a typical Western diet. Evidence is supportive of the positive effects. High intake of meat is positively associated with albuminuria, and also the production of nitrogen compounds requiring elimination by the kidneys. In contrast, consumption of fruit and vegetables is inversely associated with albuminuria. The Mediterranean diet is another option that looks at a high intake of virgin olive oil, vegetable fruits, whole grains, fish, low dairy, and low red meat consumptions. The benefits of a Mediterranean diet in transplant patients are reducing inflammation, oxidative stress, endothelial dysfunction, acidosis, hyperlipidemia, hyperglycemia, and blood pressure levels. Transplant recipients has also been shown to show an improvement in the oxidative stress of the plasma and erythrocytes, as well as an improvement on acid-base balance and glomerular hemodynamics. Thus, we strongly advocate this diet as it leads to a balanced eating plan. It's long-term and sustainable in patients and leads to an overall a positive impact and improves graft survival after transplantation. The DASH diet, there's a lot of similarities in the diet. The DASH diet is a particularly low sodium diet, and it stands for the dietary approach to stop hypertension. The total intake of sodium with the DASH diet is approximately 1 teaspoon during the course of a day. So it's extremely sodium deficient. And hypertension is, obviously it's very common in our transplant patients. The benefits of this diet are also in blood pressure, insulin resistance, inflammation, oxidative stress, arterial stiffness, and endothelial dysfunction. The DASH diet has significant evidence-based, and it's designed to reduce sodium intake and improve blood pressure. And it's also recommended for patients that are kidney recipients. There's a lot of data in the renal literature, and I think it's worth discussing at this particular occasion about why we emphasize so much on plant-based. The vegetarian diet provides more quality and a lower protein intake. Patients with chronic kidney disease risk factors or kidney disease consuming foods rich in protein causes dilatation of the arterioles, which increases glomerular filtration rate at the cost of higher intraglomerular pressure. Chronic glomerular hyperfiltration results in a decreased long-term kidney survival, especially in the post-transplant kidney population with kidney disease risk factors and lower number of nephrons. Hyperfiltration stimulates mesangial cell signaling, leading to progressive fibrosis and kidney damage. But a lower intake of dietary protein, especially from animal sources, leads to greater constriction of the afferent arteriole, decreasing glomerular damage, and stabilizing or improving kidney function. Another benefit of plant-based diets is its high fiber content, which is crucial to the gut microbiota. From Islamic perspective, the Prophet ﷺ rarely ate meat, and it's been noticed that smoke could only billow out of his house approximately every 14 days. So the assumption is that Prophet ﷺ ate meat extremely rarely, approximately once every 7 to 10 days. Hazrat Umar radiallahu also banned the daily consumption of meat. And he mentioned that the daily consumption of meat is almost akin to the addictiveness of the righteousness. And he compared that to the addictiveness potential of alcohol to an alcoholic. So I think we should make concerted efforts broadly throughout the year and during Ramadan to watch what we eat during that period of time. I'd like to wish everybody all the best for the rest of Ramadan, and then Eid Mubarak to this thing. Jazakallah khair. Thank you for listening.
Thanks, Zahir. So I don't know if you want to take a few of the questions. So we have some questions from the chat. Dr. Shabnam Adam again has asked, how long do patients take tacrolimus for? Are most of them on it for life? And what trough level is dangerous for fasting?
So I think the tacrolimus in the vast majority of patients is a preferred drug. And patients with stable graft functions, we tend to use tacrolimus quite regularly in our local context with regards to that. There are alternatives to tacrolimus like sirolimus, which can be used, but there's very specific indications for changing that. Toxic tacro levels are definitely deleterious for overall graft function, can lead to acute kidney injury, can lead to hospitalization, can lead to neurological deficits. So, it's not without concern with regards to that.
So I think the problem with the trough in Ramadan is if the fast is longer than 12 hours, the trough may drop into a range where there's a little bit of a risk of rejection. I think that's the perspective. Obviously, I think obviously tacrolimus, the normal Prograf is dosed twice a day, so that becomes a problem. But as Zahir pointed out, you can have Advograph, which is dosed once a day. I tend to accept up to like 13 to 14 hours in most of the patients. Obviously, there is a little bit of a risk that the trough then is going to drop, and then just increasing the dose is not appropriate because then you may expose the patient to toxicity at the peak levels. What do you think, Zahir?
I think it's a very difficult and emotional time to get admitted during the month of Ramadan, for toxic levels. I think with these patients, there should be a tendency to absolute conservatism, Shoaib. We have a big shortage of grafts. I think that sense of the preciousness of the grafts should be tantamount, and it's in keeping with the overall spirit of Ramadan.
Okay, Tilshad Brunk has asked that diabetics are often asked to take Ensure as a top up. How safe are these or any other high protein shakes?
I think the problem with shakes is, they tend to be hypoosmolar, and the risk of dehydration and if impacts on the body becomes problematic. High protein intake, is essentially leads to vasodilatation of your arteriole and results in an increase in glomerular pressure. And chronic increase in your glomerular pressure has signaling pathways which may result in an increased rate of decline of kidney function. So, I look at it with, again, there are certain indications where patients are not taking any protein. They have massive amounts of sarcopenia. And like many things in medicine, there isn't a one-page-fits-all response to something like that. I think we just need to understand it in a greater context. I would be concerned, to be relying only on Ensure in terms of nutrition.
Yeah, I think that's an important point that you make. I mean, it's attention to the overall nutrition. I mean, obviously, as you mentioned, if somebody is really struggling to keep up with their protein intake, they have severe muscle loss and so forth, we do give them protein supplements, especially patients on dialysis, where obviously the impact on the kidney may be not as important because the kidneys are already not working. But the majority of patients, and I think you touched on very nicely the diet, because what often happens in Ramadan is that our diet changes completely from the diet that you would have outside Ramadan. Lots of people are now having a significant amounts of fried foods, unhealthy foods, the pies and the samosas and all those type of things in excess. I mean, we didn't touch on, Zach didn't touch on it either, but dates have a pretty high potassium content, which is actually very good for you if you have normal or healthy kidneys, or if you have a kidney transplant, but may be harmful for you if you have very poor kidney function. Do you want to say anything about that, sir?
I think it's about the syrup, the spirit of what we're doing. A minuscule amount of dates, just for the, in keeping with the spirit of Ramadan. I think would be like, we're talking 1/20th of a date, Shoaib, not even a full date, just to maintain the sense of the sunnah. But I think it again is individualized. What's the resting potassium levels? What are the other medications that the patient's taking? What sort of urine output that the patient has?
Okay, and then Dr. Tarmohamed Yusuf is asking for some journal articles or references on the vegetable protein preference. I don't know if you want to comment on that, or will you send him something?
There was an excellent article I was looking at with regards to transplant patients and and nutrition. When we talk about plant-based, we don't use absolute terminology. We don't use words like vegetarianism or absolutism. I think that when we talk about plant-based, is the bulk of the diet should be plants, as opposed to a bulk of our current diets, our Western diets, unfortunately, which we have there's a significant amount of animal protein, which is forming the bulk of the base. But there's some good data about the importance of, plant-based protein, both in terms of, the gut microbiome and the effect that it has on inflammation with a variety of diseases, and in terms of cancer risks, as well as obviously with regards to kidney function.
Okay, and then Fatima Shifa is asking, what is the hadith which refers to the Prophet ﷺ consume meat less frequently?
I'm going to dig myself into a bit of a hole when I start clear up. So I'll find the reference. I'll post it online as well.
Okay, Jazakallah. Thanks, Zaid.
Thanks so
much. Are there any other questions? Zubair Asmal has his hand raised. Zubair, you can unmute.
Assalamualaikum in the panel. Yeah, just a comment rather than anything else. In my opinion, that when we have patients who come to us and you tell them not to fast, they just don't listen to you. 70, and I think the stats have shown that despite what we tell them, about 70 to 80% of patients fast anyway. So this year, what I've tried to do was I tried to do something new, and I found it was actually quite helpful. And what I did basically was I tried to persuade them in a different manner, to try and convince them that fasting might not be a good idea for them. Now, if you look at I think it was Aristotle, if I'm not mistaken, he basically said there's 3 ways in which you can persuade a patient or a person. The one is, if you are an authority, if someone big and the person looks up to you, then they're going to listen to you, right? So that's the first way. The problem with that is that we competing essentially with God. He's telling you to fast and you're telling them not to fast, at least in the mind of the patient. The second thing was to show them logical arguments, and we can show them the studies and all of that, but it really doesn't tend to convince them not to fast. And then the third way is to actually to appeal to the emotional sense. Okay. And I found that, appealing to the emotional sense and, saying that it comes from a higher authority, that actually tends to convince them. And the way to do that was, what I did this year was to show them the actual Quran ayah, which refers to fasting and, where Allah commands us to actually fast. Now, in the second juz, in the second part of the Quran, Allah mentions 3 verses essentially, which basically convinces you, where he actually commands you to fast. So the first verse is where he introduces the fasting, and fasting is prescribed for you so that you may earn, God consciousness. And the second verse is, where he mentions that it's just but a few days. And then, as people have mentioned later on, or, during the talk, that, Allah mentions that if you are sick and you're on a journey, then, you absolve from fasting, And then in the third verse, I think that basically captures the whole thing, is that Allah mentions, and he starts off by saying, Shahru Ramadan alladhi unzila fihi al-Quran, that, we have indeed revealed the Quran in the month of Ramadan. And the reason why he revealed it was, it is meant to be your criterion from what you judge. And then after that, interestingly, Allah mentions again, that,
right, yeah.
if you are sick or you are on a journey, they don't fast. And then the verse that comes after that is, yuridu Allah bikumul yusr wa la yuridu bikumul usr, that, Allah intends to make things easy for you. So, it doesn't intend to make things difficult for you. So if you tell the patients that hey, Allah wants, he wants to make things easy for you. He's giving you this leeway. And, if you don't, don't make things difficult for yourself. If Allah is telling you, if you're sick, don't fast, just pay the fidya. And I think that tends to convince them, eventually that, fasting is actually detrimental to their health, and then that might help. So I just thought that might help, people who are dealing with other patients, just by showing them the verses that actually might convince them actually not to fast when it might be detrimental to their health.
Yeah, thanks for that, Zubair. I think that's an excellent approach. I mean, I use a similar approach. I think what happens is that patients have this overwhelming sense of guilt that they should be fasting and they're not fasting, and but when you point out to them specifically, as you mentioned, those ayats which which, as you allude to, give them the leeway not to fast, and also tell them that Allah subhanahu wa ta'ala is trying to make it easy for them based on their affliction. Many of them understand it, but as you say, still a lot of them will want to fast. And as Zach and Zaira pointed out, where they do insist on fasting, then you have to sort of try and individualize, look at how to mitigate the risk to them and explain to them the risk to them. They have to go into it with their eyes open and then take every sort of other effort. And then certainly there's some patients where medically the risk would be minimal to small, as Zaira's pointed out, those with stable graft functions several years after transplant, good kidney function, stable medication, once-a-day medication. So I think we sort of obviously don't want to stop people fasting who can safely fast as well. Are there any other questions? So I think we can move on to our third talk, if there are no further questions. And Jazakallah, thank you, Zair, and that was an excellent presentation as well. And I think we have much more information than we had before we started. So we go now to our third presentation. Our third presentation is by Dr. Zunaid Bardey. And Zunaid qualified with his undergraduate degree at the University of Cape Town, but we still love him. After a brief stint in general practice and as an MO at Livingston Hospital in Port Elizabeth, where he partially lost his Cape Townian accent, he trained as a physician and then a nephrologist at Grooteskill Hospital in Cape Town, where he gained it back, and he continues to work. He runs a renal transplant clinic and is involved in all aspects of living kidney donor assessment and post-transplant care of kidney transplant recipients. More recently, he has been involved in starting the first ABO incompatible kidney transplant program in South Africa, as well as the first kidney paired donation program. He also looks after renal failure patients at the UCT and Athlone kidney and dialysis centers. And his research interests include desensitization and immune suppression protocols, as well as HIV positive kidney transplantation. A really distinguished and excellent colleague and nephrologist, and we welcome him. So Zunaid is going to change tack and look at general religious and cultural barriers to organ donation. So assalamu alaikum and welcome, Zunaid.
Wa alaikum salam, Shoaib, and to all the participants, thank you for having me. Can you guys, I hope you can all hear me.
Yes.
Okay, great. Okay, so I'm going to start with some disclosures. They seem obvious, but I'm just going to put them out there. So I'm a nephrologist mainly involved with looking after transplant patients. And so I'm obviously going to be pro-organ donation in my outlook. And then other things, like you said, I'm from the Western Cape in Cape Town, so I'm going to just focus a little bit on that aspect, a little bit more than the rest of the country and the world. I am a Muslim, so there's going to be a focus, and this is an IMA sponsored functions talk, so I'm going to focus a little bit more on the Muslim aspect of these organ donation issues. But to say I'm not a religious scholar or an alim, so just forgive me if there are any errors from a religious point of view. So we're going to just, like I said, talk about the South African transplant overview. We're going to then look at religious and cultural barriers to organ donation from the South African context, then move to look at the international perspective and other religions, or sort of a variety of world religions, and then I'm going to come back and focus on Islamic perspectives on organ donation. So just to say a little bit about transplantation in South Africa. This is from a recent SATS publication looking at transplantation statistics covering the period 2017 to 2021. As you can see, there's quite a few places where transplantation takes place. Well, I mean, mainly the two main centers are in the provinces are in Gauteng and in the Western Cape, and the two biggest centers are obviously in Joburg and Cape Town, where multi-organ transplants take place, including kidneys, liver, lung, heart, etc. But there are other places in Durban, and I do believe still in Bloemfontein, where kidney transplantation does take place, and I think in Durban there's still one center where heart transplant take place. So that's what happens in South Africa. If you're looking at deceased donor organ transplantation in South Africa, they looked at the stats, and you can see there's been a slow decline over the last couple of years, probably related to COVID. And you can see from this graph that there's still a slight majority of consented deceased donors are from the private sector. If you look at the number, the absolute number, there's, it wasn't around the 90s and then dropping down into the 40s donors per year in the whole country. So, we're a country of about 60 million people. And if you look at this graph, it shows that we would fit right at the bottom end of the scale with countries like Algeria, Lebanon, Dominican Republic, Bolivia. Those are right at the bottom end of the scale in terms of how many consented organ donors there are per million. I mean, if you compare that to Spain, where it's about 30 times as much, and countries that we often look at, the UK is about half of Spain, about 15. So we're way behind. Coming back to that organ transplant activity, so this is looking at three things: the deceased donations per year in the yellow, and you can see that's dropped off in terms of organs that were received from deceased donors. In the red now is living donor organs, which would be mostly kidneys and some liver transplants, and then the overall numbers in the blue. And you can see, well, there's been a drop-off again in the last 2-3 years, and that still most organs that are transplanted are from deceased donors. Okay, and then just looking at it by province, you can see the two standout provinces, like I mentioned, are the Western Cape and Gauteng. That's where most transplants occur in the country. The Gauteng data might be slightly pooled data from the surrounding provinces that refer to Johannesburg in particular. Okay, and now we're going to just focus on the Western Cape, where I'm from. Groote Schuur Hospital is where I practice. This is the old hospital where it was famous for where the first heart transplant occurred. And if you do get to visit, you can go visit this museum where they recreate the first heart transplant by Chris Barnard. This is the old hospital and the new hospital, which is where we practice. The old hospital is now mainly administration. So, okay, I'm jumping a bit past there. Just to talk about transplantation at Groote Schuur Hospital, in terms of the kidneys, we do deceased donors and living donors, obviously. And besides for donation after brain death, we do donation after circulatory death. I don't think there are any other hospitals in the country doing that, and that might be something that we need to encourage, especially for we'll come to it later on, where there's issues with brain death amongst certain religious groups. Obviously, living donation, like I said, we do the normal living donation, but just started doing this ABA incompatible. We're working up altruistic donors, and like I said, we've done some KPD, although that's at the moment on hold because mainly of software issues. And then, of course, the heart transplants, liver and lung transplants do occur in small numbers. Just stepping back again, in terms of the transplant landscape in Cape Town, we've got 2 private hospitals doing transplants at the UCD Private Hospital and Christian Barnard Hospital, and then the 3 state hospitals, Groote Schuur, Tygerberg, and then, of course, Red Cross Hospital for their children. Okay, I mean, just some stats about the city and the population mix up. It's quite a mixed population, and we've got lots of people from surrounding countries living in the area, and quite a mix of religious groups as well. So that's what we're going to focus on. Still, obviously, predominantly Christian, but we've got quite a large Muslim population. I mean, probably closer to 10% now, and we've got representations from lots of other religions and cultural groups. So yeah, I mean, just what has the experience been? And I just have to mention again, I've got a lot of these slides and some information from our transplant coordinators, in particular Fiona McCurdy, which I'm sure a lot of you know. So when they've done a review of the why people, which patients consent and which don't, and why they don't, they find that in the private sector, the consent rate when they ask for organs is about 75%, but in the state hospitals, it's about 25%. And that's not really because there's a difference between the coordinators. It's obviously, we think, mainly because of the different profile of patients. The private patients are more middle class, firstly, and they're obviously, because they're on medical aids, and the one in the state hospitals, obviously from a more low socioeconomic group, not on medical aids. And there are some religious and cultural issues which they've picked up over the years. The Christian families, when they say no, they often, it's because they expecting a miracle. They want the body to go back to Jesus in an intact state. I've had a comment that if you see a pastor involved, then you're much less likely to get consent. Because whatever they are counseling the families. If there's families from a black background, they often need to speak to the family elders. There's a system of consulting the ancestors, and there's also some families where there's a Christian influence to that. In terms of the Muslim families, the comment was often is that organ donation is not allowed, and when asked like why that is, they said it's just common knowledge in the community. There's other socioeconomic factors, such as families that are very scattered and difficult to get hold of to get the consent. There's unemployment and safety issues and poverty. So public transport and getting hold of people on a phone might be an issue. And there's often just poor education and insight and awareness around organ donation. And then the other priorities like, just food and housing and safety, and organ donation is not really an issue. So in the reality, South Africa is an upper middle, well, it's classified as an upper middle income country, but there's very wide disparity in the population, and we've got that highest Gini index that people quote between the most wealthy people and the least wealthy, or earning the lowest income. So in theory, cultural and religious leaders say that organ donation is permitted, and we'll go through that a bit more, but in practice, it's not that straightforward when dealing with families at a very difficult time. And socioeconomic, education, religious and cultural factors are often intertwined. So just to look at one or two studies that have been done, this is from way back in 2004, where they looked at in a Zulu community. There was generally a lack of knowledge about organ donation, and there was a misconception about organ donation related to the Zulu beliefs and around death, burial, and in the life in the year after, and their values and social structures. So they concluded that cultural sensitive promotion of organ donation was needed. On the positive side, the Organ Donation Foundation, Organ Donor Foundation, has started a project a couple of years ago called the Uluntu Project, which is an education project which they want to educate people in the community, and in fact the word means community, and they try to get people out into the community and make the people at that level aware about organ donation. And it's about addressing a problem that's far too many people don't actually have factual knowledge about what's involved. So to give them the facts and allow them to make an informed decision. Just looking at, so that's the South African situation, and it's actually not that dissimilar, I mean, throughout the world. And we're just going to look at a few studies that have looked at what the issues are. So there's quite a large amount of literature, and two themes that have emerged is that, firstly, the world has changed a lot. There's a lot of movement of people, as we're aware, from one country to other. There's lots of refugees, a lot of people that are resettling in different countries, and communities that were sort of previously quite homogenous are now quite mixed. And there's quite a lot of beliefs and cultural mix which you have to take into account too when looking at these studies. So it's just some snippets from around the world. So this study from 2012, they They looked at the various faiths, including those listed there: Christianity, Islam, Judaism, Hinduism, Buddhism, Shintoism, Confucianism, and they all had sort of slightly different takes. And I mean, in terms of Christianity, the overall view was that it's a worthwhile act to donate organ, and it's an altruistic act. With Islam, the focus is on trying to save a life. That's the pro, but there's issues with violating or harming the body. With Judaism, the issues around desecration of the body and also around brain death. Hinduism and Sikhism were quite pro the organ donation, but there was because they're not so concerned, about what happens to the body, and there's a thing about doing good. Buddhism, the issues there are that the spirit is alive in the body after death, and so that's slightly against, but it's a selfless act, and giving is very important to in Buddhism. Shintoism, which is practiced in Japan, they have issues with bad luck to interfere with the body, so and that's why deceased organ donation doesn't really occur in Japan. Confucianism, we should die with a complete body, is on the one side, versus the value of sustaining life on the other side. So looking at some specific studies from different parts of the world, this is from America with African Americans. There were a couple of studies, and they concluded that the clergy had no religious concerns about organ donation. The residents had concerns, and that religious leaders need to be, do more about educating to play a role in promoting organ donation. Another study, this is now looking at people from the Caribbean area, in the Caribbean, in Barbados, and they looked at a population, originally from the Caribbean in the UK, and they found that the people from Barbados were actually more willing to donate kidneys after death, less so in a London Caribbean population, and they identified the barriers to be related to issues around being an ethnic minority and feeling marginalized in these high-income countries. Looking at a Libyan study, they found that 29% were in favor of donation after death, so not that much, and they were mostly, those that were mostly male, younger, graduates, and single. Those that refused cited a lack of knowledge and uncertainty about the religious implications, and they concluded that public education should be coordinated with religious leadership. A study from Iran, and in Iran there's been fatwas passed to say that it's organ donation is allowed. So the religious leaders' positive attitude towards organ donation can be effective in making Muslims more inclined to donate. And this study looked at 400 freshmen from Mashhad University, and so the medical university, and 41.5% were aware of the religious authorities' view on positive view on organ donation, and 55.6% were willing to donate. And they concluded that students who were aware of the religious leaders' opinions were more than twice as willing to donate than students that weren't aware. A study from Israel. Recently the Council of the Chief Rabbinate had formally accepted neurological brain death criteria for all religious and legal purposes. So they removed that the Jewish religious barrier or legal barrier that had been in place. So they found that 25% of the Zionist ultra-Orthodox community were willing, only 25 were willing to donate, but that number went up to 68% when they were informed that now this, that the rabbinate had now allowed organ donation. So they concluded that public support for organ donation by authoritative and accepted religious leaders is required to promote organ donation amongst these very orthodox religious groups. Another study from the UK where they looked at people attending a GP practice. They found this was now before the UK opt-out system was implemented recently, and they found there was a low rate of registration as a kidney donor by ethnic minorities overall, and it wasn't only explained by cultural and religious barriers. So again, and minority ethnic groups in general were less likely to be wanting to donate. And they said that there was understanding self-identity, minority group issues, cultural beliefs and religious practice, and social capital of communities was required. And like I said, now the UK has subsequently moved to an opt-out system, which means you considered an organ donor unless you've formally informed the government that you're not. And there are quite a few countries that are taking this route. A Swiss study, and this was interesting because they looked at different language-speaking groups within Switzerland. As you know, there's quite a large German, French, and a smaller Italian speaking population, and they showed even within those population, within the different language groups, they call this microcultural differences. They found there was quite different attitudes and likelihood to donate organs. And then just looking at again in the North American and this now the Canadian context, they look at Indo-Canadians, Chinese Canadians, and then what's called Coast Salish, which are Native American Canadians. Overall, there was a reluctance to discuss death and related issues such as organ donation. There was little knowledge about organ donation and possible influence of spiritual or cultural values. And there was tension between contemporary and traditional perspectives. And they concluded that beliefs varied considerably. And then you also shouldn't make assumptions about, just based on what population group or what religion the patient says they are as to how, if they are going to consent or not. And again, the Sikh community in the UK, they found that there was generally a supportive view, and in Sikhism, altruism is quite a strong tradition, but they did have some issues with mutilation and reincarnation. So barriers to organ donation have more to do with knowledge and understanding than cultural or religious factors. So when they weren't donating, it wasn't because they were Sikh. And basically, they need more information and literature. There was this study, which was a Greek Orthodox community in Australia, and again, there was lack of knowledge, and they needed more information around it to before they could make proper decisions. So one final study from the UK, where they looked at lots of different religious groups, and they found that the majority opinion was to permit organ donation, and that was across all religious groups. But within each group, there's a broad spectrum of opinion, and problems occur when because there's no explicit reference to organ donation, obviously in the original religious text, which a lot of these religions obviously are quoting, and positions on donation and receiving organs are based on interpretation of scholars, and obviously scholars can have different opinions. And the default opinion when at the time of death, and when people are asked to donate the organs of their deceased family member, is to move to what the so-called religious right, which means take a more conservative approach. And again, more awareness and understanding and education was necessary. So we've mentioned brain death quite a lot, and it might be just worth talking about what brain death means for the non-nephrologists or transplant people on the talk. So it's quite a new concept. It was first actually described in 1959 by Molleret and Goulart, I hope I pronounced that properly. And it was in patients who had irreversible comas, as they called it then. Further developed in the 60s, and it actually arose because of the invention of the ventilator, or the lung machine which breathes for patients. So artificial ventilation can keep the heart beating because you're providing oxygen to the patient even when the patient can't breathe for themselves. And the respiratory center for breathing is in the brainstem, or the back of the brain. So I mean, it's been developed to such an extent where there's now internationally accepted criteria for diagnosing brain death. And if it's done correctly, brain death testing is basically 100% accurate and exact. So if somebody's properly been assessed as being brain dead, there's no chance of them recovering. The heart is only kept beating in this situation because the blood is being artificially oxygenated by the ventilator, and the heart does stop beating within minutes of switching off the breathing machine. So, and it's also important to know that the brain dead person's brain is actually not receiving any blood, because there's such a severe brain injury and swelling that blood can't actually perfuse into the skull. So this is just not a very clear picture of somebody that's in a coma, and they've done a arteriogram, and they're showing blood flowing to the brain, and in somebody that's brain dead, there's no blood that gets into the brain. So the brain literally is infarcted and actually becomes liquefied within a few days, because there's no blood and there's breakdown of tissue. Just to say something again about brain death from different religious perspectives, and I'm not focusing just on organ donation, but brain death. So, like I said, the Japanese are unwilling to accept brain death because they've got beliefs about what happens to a person after death. There's cultural resistance to mutilating the body, and there's a concept of impurity associated with a dead body. Hindus and Christians, there's debates on brain death decreasing, and now more people are accepting that as the acceptable criteria for death. Hinduism in particular has got a concept of karma and philosophy of helping others, and supports organ donation, transplantation. But the tradition of cremation of the body and belief in untouchability could slightly argue against that. Buddhism, like we said, there's not much significance attached to the body after death, but it's considered a good thing to respect it. Therefore, overall, there's no objection to organ donation. And most developing countries still have problems with understanding the concept of brain death by the public, and even medical personnel accepting and understanding the different cultural meanings of death. So, is deceased organ donation permitted in Islam? And in fact, it comes down to, there's no one answer. There's three sort of camps, if you want to call it that. There's the impermissibility camp, which says that organ donation threatens human dignity, and they support this view with statements, from the Prophet Muhammad, which are the hadith. There's the contingently camp. I think that it's a contingency. Sorry, that should be. And that says organ donation is supported by Quranic verses and legal precedents, and that those overrule the prohibitions, because when there's dire need, and cases where organ donation is life-saving and thereby another person's donation of an organ is necessary are held to meet the standard of dire necessity. And then there's the general permissibility camp, in which that say that human public interest, namely the duration, the quality of life of a person, is furthered by organ donation, and they argue from, again, scriptural and other legal arguments to support this view. So if you look at looking at Islamic principles around this, organ donation and transplantation is not specifically mentioned, like in other religions, in the main sources of Islamic law, namely the Quran and Hadith. So the rulings are based on general principles from these sources. And while there's a diversity of opinion across the globe, there are geographical and legal school overlays to each opinion. So in general, scholars from the Indo-Pakistani subcontinent and those belong to the Hanafi school typically advance the impermissible or contingently permissible view. Scholars in the Middle East and those from the Shafi and Shia backgrounds tend to say it's permissible. And most Muslim countries are if you look at it at a governmental and legal level, do support organ donation from deceased donors, and that includes Saudi Arabia, Iran, Egypt, Malaysia, and Islamic councils in countries where Muslims are minority, including the UK, USA, Canada. Just looking at the UK, and they were quite progressive as far back as 1995. Their Sharia Council declared that the medical profession is the proper authority to define signs of death, and current medical knowledge considers brain stem death to be a proper definition of death. The council also accepted brain stem death as constituting the end of life for the purpose of organ transplantation, and they supported organ transplantation as a means of alleviating pain or saving a life based on the rules of Sharia. And Muslim may carry donor cards, and the next of kin of a dead person, in the absence of a donor card or an expressed wish to donate their organs, may give permission to obtain organs from the body to save other people's lives, and organ donation must be given freely without reward, so trading in organs is prohibited. So that's basically pretty much what we would say in a practice even in most countries, including South Africa. So what are the this was an interesting study that actually came out quite recently, October last year, from the British Islamic Medical Association, and they did a nationwide series of community gatherings with the aim of describing the beliefs and attitudes of organ donation amongst British Muslims. So this was following this opt-out law that was passed in the UK, and they also evaluate the efficacy of national public health programs on views and uncertainties regarding religious permissibility and willingness to register. So there was, when they had the opt-out law that they passed, they had to make the public aware, and they had these education programs, which obviously included educating the Muslim population. So that these 8 public forums across the UK between June 2019 and March 2020, and the forums included a panel of experts consisting of health professionals and imams, and they discussed with the audience the procedures, experiences, and Islamic ethical legal rulings on organ donation. And attendees completed a self-administered questionnaire which captured some demographic data, but also the opinions before the session, the education session, and after. And they had 554 respondents across 7 cities. The male to female ratio was basically 1-to-1, and only 8% of the people that had responded were already organ donors. So this is quite a complicated diagram, but basically they tried to summarize what they found. And just look at the top first, when they looked at question 1, which was, does Islam permit organ donation? And the inner ring is before they did the session, and the outer ring is after. So if you looked at the people that thought it was permissible or halal, that group didn't change by the education. Those that were unsure, there was quite a large percentage, most of them then afterwards agreed that it is permissible. Those that thought it wasn't permissible or haram, about half of them then actually did think it was permissible. And then they asked another question, is now, if you thought it's now permissible, would you be willing to register as an organ donor? But obviously, or actually, most of those that thought it, it is permissible, stayed like that. There were an odd few that changed. Those that were initially unsure said most of them now said they would register, and some of those that had said initially that it wasn't allowed and wouldn't register did. And this is just another way of summarizing it. So basically there was quite a big shift from people that initially thought it wasn't permissible and wouldn't register to those that would afterwards. So it seemed like quite a positive information session, and it did involve the imams as well. So just to go back again to what are the Islamic arguments that say that organ donation are allowed, if you go into the specific points. So firstly, deeds are judged by the intention or their goals, as we've heard from the previous speakers about why are we fasting in Ramadan. So the purpose of organ transplantation is to save a patient's life, and organ transplantation is not performed with the intention of harming the deceased. So organ transplantation, the second point, is it fulfills the objective of preserving human life, and God promises great reward for the effort of preserving human life. And if you look at chapter 5, verse 32, the second half says, if anyone saved a life, it would be as if he saved the life of the whole of humanity. The third point is that organ donation is an ease made available to mankind to overcome hardship faced by patients with end-stage organ failure. And this is supported by the Quranic verse in chapter 2, verse 185, God intends every ease for you. He does not want to put you through hardship. The next point is that charity, or if it be it zakah or lillah or whatever, any form of charity is a central pillar of Islam. So donating an organ without wanting to be paid back can be considered the ultimate charitable act. Sorry, I've got my numbering wrong. That should be point 5. The concept of necessity making prohibitions lawful exists in Islamic law, and the only option to save the life of a patient with end-stage organ failure may be organ transplantation, especially when if you're looking at non-kidney transplants, when dialysis maybe is an option there. So in particular, patients with lung, liver, and heart transplants. And this is supported from the verse in chapter 2, verse 173, which says, "But if one is forced by necessity without willful disobedience, nor transgressing due limits, then he is guiltless, for God is oft forgiving, most merciful." And then the final point is that permissibility is the default state in Islamic law. So a verse which illustrates this is in chapter 31, verse 20. "Are you not aware that God has made subservient to you all that is in the heavens and all that is on the earth, and lavished you with his blessings, both outward and inward?" So basically, unless something is expressly forbidden or contravenes some other Islamic principle, then it's generally considered permissible. And then just the issue around brain death in Islam. So there's, again, three views. There's, one view is that accepted neurological criteria for brain death based on the modern medical testing is allowed. So organ procurement can continue while the heart is still beating. Then there's another view where they say they accept the neurological criteria, but that then allows the withdrawal of life support systems, and death is not legal until there's cardiopulmonary arrest. And then the third view is that organ donation is not accepted at all, regardless of the criteria, of how death has been defined. So interesting. In the second view, I mean, would allow for donation after circulatory death, and as I said, it's something that we really need to look at in South Africa, to extend that to more centers that offer this as an option. Okay, and then this is probably quite a controversial slide, but I'm going to put it in there. So is brain death discussed in the Quran? And I mean, the short answer would be no, but there is this verse in chapter 39, verse 42, which says, in the translation, it is God who takes away the souls of people at the hour of their death, and takes away at the time of sleep the souls of those that have not died. Then he retains the souls of those for whom he has decreed death, and returns the souls of others until an appointed time. Surely these are signs for people who reflect. So, I mean, just to reflect on that verse, I mean, God states that in the Quran that souls are withdrawn from our bodies when we sleep and return when we are awakened. And interestingly, in the Cape, sleep is even referred to as the klein dood, or small death, if you don't understand Afrikaans. And just to go back, the brainstem is permanently damaged in brain death, but the part of the brain which allows us to awaken from sleep, which is the reticular activating system, is also found in the brainstem, in the same part of the brain. So in a way, if the brainstem is permanently damaged, this small death of sleep becomes the big death of brainstem death. And based on this, it could be argued that the brainstem criteria for brain death should be the accepted Islamic criteria and not cardiopulmonary criteria, which is not actually discussed in the Quran. But like I said, it's a very controversial, and I mean, it's definitely not a accepted, widely religiously accepted view at all. And just to finally say that there are countless people over the centuries that have been declared dead by cardiorespiratory outward criteria, and that actually have even been buried that were not actually dead. So, cardiorespiratory criteria can also be tricky. So just to go back to our experiences, mainly in the Cape, as I said, why do so few Muslims actually end up donating organs? And I mean, like I said, the Muslims make up about 10% of the population of the Cape, and about 10% of the people on the waiting list when we looked at it. But less than 1% of deceased donors are Muslims. So in South Africa overall, I would say that Muslims are not donating organs, but they are willing to receive organs, and I mean that's obviously not a very fair way to be doing things. And when you ask people why, like I said, they just say it's not allowed, but they can't really say why not. And also, who told you that? And again, like we said, it's common knowledge in the community. So there seems to be a problem, in terms of the religious, leaders conveying the message to the community. And just again, in the Cape, the MJC a few years ago passed a fatwa actually saying that organ donation is allowed, but families are not aware of it. the fatwa didn't really, I mean, it didn't accept brain death as a criteria. But when it comes to Muslim families, they don't really, brain death doesn't even come up really as the concern. And like I said, at a critical hospital, I mean, in particular, we do offer donation after circulatory death. And then sometimes, the issues around burial come up, but time-use burial is not a concern. Because firstly, there's often a medical legal autopsy that's required anyway, and in most cases, burial is expedited for Muslim patients. I mean, we even had a case of one of those very few Muslim families that did agree to donate. When we called one of the recipients to come in for the transplant, she was actually attending the deceased patient's funeral. So I mean, just showing how quickly the funeral did take place anyway. So in summary, factors contributing to cultural and religious barriers to organ donation do occur. There's a lack of knowledge of people's own religions and culture, and what is sort of normally acceptable. There's a lack of knowledge about organ donation and transplantation by faith leaders, and educating the communities. And there's an influence of socioeconomic situations throughout the world, and there are those subtleties which overlay what might be the main religious concerns. The take-home message is that while there are issues relating to culture and religion which can negatively impact donation, these are not insurmountable barriers, and the transplant community needs to increase cultural sensitivity and competence around what the views out there are. And they need to engage public and religious leaders to increase understanding and information sharing, and organ donation needs to be discussed by everybody in our homes and from the pulpit or the member or wherever it can be discussed by the religious leaders in particular. So I'd just like to thank you for listening. Sorry, it was quite long. And again, I'd also like to thank Fiona for sharing quite a few of the slides with me. Back to you, Shoaib.
Jazakallah, thanks, Junaid. Thanks for that. I think obviously there's a lot of food for thought there, and we have a lot of work to do. I was sort of disconnected for a few seconds there, so my chat is reset. So I don't know if there were any other questions, but Yazid has got a question. How many Muslim donors have we had in the Western Cape in the last decade?
I can't give you an exact number, but I mean, it's in the last decade. I mean,
yeah, decade, 10 years.
It'll be literally a handful. I would say if it's more than 5, I'd be surprised. Yeah.
Yeah, and I think we have a similar situation in Johannesburg. I don't know if we've had a deceased Muslim donor ever in Johannesburg. I can't say that we have. Obviously, living donors are a whole other story. We didn't touch too much on that, but we have a hell of a lot of Muslim living donors, and there doesn't seem to be any societal sort of opposition to that. And that seems to be quite willingly done, especially in the common categories, mother to child, father to child, wife to husband, and then the odd husband to wife. For some reason, that's less common.
Yeah.
And then brothers and sisters. That happens fairly often.
Yeah. No. Across most societies and religions, there isn't an issue with living donation. And I mean, I always find it a bit surprising because I mean, you can do so much more potential harm to a living donor than to a deceased donor, you would think. I mean, but anyway, that's a separate argument. I mean, there isn't an issue with living donation.
So you mentioned quite a lot that this opt-out system that the UK has talked about, and maybe many of our attendees may not be clear as to what that means. You maybe want to point it out to some people.
Okay, sorry, we're getting a bit of interference, but okay. So yeah, the opt-out system, I mean, there's various systems that have been taken throughout the world, but the opt-out one is probably the most aggressive one, where they assume everybody in the country is going to be a donor unless you have said before you die that you don't want to be a donor. So it does require a lot of the whole country to be aware of this new law. and to make whatever the legal channel is, which presumably they have to make it quite easy for you to then say that you're not a donor.
Sure. So the other comment from Yazid is that one of the obstacles to donation after cardiac death, and maybe I'll just explain for many of our listeners who are not experienced with transplantation. So donation after cardiac death is where somebody is brain dead or likely to have severe irreversible brain injury, and the family agrees to withdraw care. That means they agree to stop the ventilator and the machines, and then you await brain death. And then once brain death, you wait circulatory death, you wait for the heart to stop. And once the heart is stopped, that's when the organ donation process can begin. And obviously different centers have different times. In some, the heart must be stopped at least for 5 minutes, 10 minutes, 15 minutes. Obviously, the longer you wait, the higher the risk to damage to those organs. So I think in some of the more advanced centers, they have an EEG. The EEG flatlines completely. Maybe after 5 minutes, they then commence with the organ donation. And one of the problems that is, and Yazid's comment is that you need resources and logistics. The surgeons must agree, the theaters must be available, and the processes must be available to cool the patient and so forth and so on, and harvest the organs as soon as possible after this. And that may be an obstacle. Do you have anything to say about that, Zunaid?
Yeah, it actually, surprisingly, if unless you think about all those other logistical issues which Yazid has mentioned, it actually is more difficult to find these patients as donors, because the thing about brain dead donors is they are mostly stable on a ventilator, and they can stay stable, like I said, even while that brain has died and is actually infarcting and liquefying for hours to maybe a day or two. So there's more time to plan when you're going to take the patient to theater and have the surgeons available, the theater available, etc. Whereas with donation after circulatory death, it's often not as predictable. So the way we do it at Grooteskier is when the family is consented, the patient isn't brain dead, or the very rare cases, although we haven't had many of those where the patient, the people don't agree with brain death, is that you then extubate the patient, and you can either do that in the ICU or preferably in the theater where you're going to operate. The patient is inevitably going to die, and then you extubate the patient, and you give them an hour to see if the heart does stop beating. And then when they do, you also don't. There's a period of not doing anything with the patient. I have to confirm exactly if it's
as I mentioned, it varies from like 5 to 15 minutes, depending on the center.
And then afterwards, once you're sure that there's going to be no spontaneous breathing or heartbeat, then you proceed. And the family can even come to theater and be there, to say their final goodbyes before the operation starts, to retrieve. And at the moment, it's only kidneys that we're doing at Grooteskier, but other centers, they do use other organs as well.
Yes, obviously kidneys are the least susceptible, to that sort of warm ischemic time. The heart, the intestines, those are extremely susceptible to that. Liver, so I think those become less likely to be able to do. Another question from Zahir, or a comment: with higher rates of trauma, is there move towards opt-out from a legislation perspective? And I know, Zunaid, you're also on the Ministerial Advisory Committee on organ transplantation, and Rafiq was also in this meeting. I don't know if anybody want to comment on that particular aspect, whether there's a general or governmental move to change our milieu around organ donation.
Yeah, look, the opt-out system is really, it's always been resisted in South Africa and other countries where the levels of education and the reach of governmental structures to reach every single person or adult in the society is not that good, because you need to first educate people. You can't just impose this law on people and they haven't heard of it and they don't have a way to interact with it. So from the Ministerial Advisory Committee, that's not really still been punted, because that really hasn't changed much in terms of in terms of reaching the population at all levels. What is being thought about is the concept of required referral, which means all medical doctors should be referring all potential donors, deceased donors, because at the moment it's really up to the individual doctor that's looking after a patient that's brain dead, or potentially could be a donor after circulatory death, to refer. There's no requirement for them to do that, and I'm pretty sure that the vast majority of potential donors in this country are not donated. I mean, there are some hospitals which are very pro organ donation, where probably a much higher percentage of patients are referred, but there's many potential donors that go missing throughout the country. And I mean, if all those donors were referred, and even if we consented 25% or even less of them, we could sort out a huge amount of our dialysis and transplant waiting list.
So I mean, one of the things about the opt-out is in terms of implementation. Some countries have an opt-out with a strict opt-out system. That means the person is deemed to be a donor unless they opted out, and then they act on that at the time of at the time of brain death, and that organ is taken whether the patient's family wants it or not. And then most of the countries, however, use the opt-out system, have a fairly lenient system. It seems to be more of a way to bring organ donation awareness, and to almost make it compulsory, so that people have to think about it before. And I think I take your point that in South Africa, we have limited education, but perhaps if we had a graduated opt-out system over like a 5-year period, where people are asked to make a decision together with education programs around the country, added to the life orientation curriculum in school, and many other things, which would help to educate the community, I think it could be workable. I know Prof. Musa was also on the call. I don't know if he wants to say anything. Rafiq, if you're listening.
Yeah, no, thank you very much, Shoaib. I think that there are a couple of issues. The one is that was raised about we have one of the highest accident rates in the country. So theoretically, just on from that point of view, there should be enough organs just on a Friday or a Saturday night, I think at Barrow or Proteski, to supply the whole country. But I think we just don't have the resources to be able to harvest those organs, or in fact we, so that is one issue. There are potentially enough organs, but just the resources to actually accept them. I think the second point is that something that Zunaid has already mentioned is education of the doctors. And I think although we talk about the lack of education among the public, I think there's in fact a bigger problem among our colleagues. And it's not unique to us. I think there are many parts of the world where the doctors are very apathetic and just don't bother to refer. They're just not interested. So, before we start educating the public, we also need to start educating our colleagues that work in in accident units, and the neurosurgeons, and people that actually work with potentially with potential donors. So I think at the Ministerial Advisory Committee level, we also now going to be looking at ways of increasing deceased donation. I think we're doing very well with the living donation, but the ideal transplant is in fact an organ from the deceased. I think one always feels a bit uncomfortable taking organs from a healthy donor. And that's why I think as a country and as nephrologists and healthcare professionals, we really should be promoting and advancing deceased donation. So I think that's all I will say for now, Shay. Thank you.
Okay. Jazakallah, thanks, Prof. And then, so one of the other comments that Tasha Meredith has brought up on the chat is that one of the barriers I found when discussing donation with Muslim families is that they're concerned about doing specific rituals that they may not be able to take place. So not so much about whether donation is allowed. So you'll be talking about obviously the ghusl and earlier burial. I think obviously a lot of this may be education, because much of this shouldn't be so adversely affected, Zunaid.
Yeah, I mean, look, there is that potential concern, and I mean, there is going to be a slight delay in those things. But like I said, I mean, I did quote the example. I mean, that you know, the one lady was called from the funeral of the deceased to come in for an organ transplant. So it should still be allowed transplantation to occur. And I mean, for me, you know, the potential good that you could do should far outweigh all those concerns. But like I said, you know, and it was quoted in quite a few of the studies that at the time of death, people, you know, they just revert to the pathway of least resistance and, you know, take a conservative approach. And to me, I mean, it's quite sad. I mean, you've got the opportunity to do such a, you know, a good deed. I mean, saving so many potential people's lives, and there's this concept in Islam of sadaqah jariyah, you know, like an ongoing act of good that will, you know, carries on, you know, almost perpetually. I mean, obviously for the lifespan of that potential of that recipient that would receive those organs, or those multiple recipients. So it's just, you know, you've got this opportunity as a family, you know, to, and even if you've you know, agreed and told your family beforehand for the deceased, you know, to have such a great act of kindness and charity that you could do, and then just worrying about an hour or two that might be lost in burial seems like a sad way to look at it.
So I mean, yeah, you know, the point you made around bringing it up from the member is critical, because I think one of the things is, and I mean, I've had a personal experience of this where you know, a young person was involved in an MVA and was probably brain dead, and it was sort of, you know, distantly related to us. So I was there and I brought up the concept of organ donation, but it was actually practically abhorrent to the family at that time. Like, why would you be thinking of this, you know? Because the reality is we haven't discussed this beforehand. It's not a conversation we have on our dinner tables and amongst our family members and what we would want to do as individuals. And as you know, in South Africa, even if you've registered as an organ donor and you have an organ donor card, at the time of your death, whether it's brain death or any other death, your family will be approached. And it's important that I mean, we bring it to the attention of our community that it should be well before, you know, while you're still alive and well, that you don't, in Islam, we think about death all the time. It is recommended to think about death all the time. And I think this is one of those aspects that we should think about, that when I die, maybe there's an opportunity on the outside. And we know the minority of people will die in a way which makes it possible for them to be a brain donor. Maybe 1 in 1,000, 1 in 2,000 people will die in this particular way, where they are brain dead or they're on a ventilator and there's the opportunity for donation after cardiac death. It's not the way the majority of people die. But in that instance that you die in that way, where your organs could be of benefit, you know, you should discuss it with your family. We should bring it up on our dinner tables through our Islamic organizations. And I think that's maybe the answer there. Salim has asked, I mean, a similar question from all nephrologists on the panel and the chair. Although we're debating the permissibility and impermissibility, anecdotally, what have you guys experienced with Muslims at the time of discussing with Muslims, and especially religious leaders like Maulanas and Sheikhs in particular, where they have directly faced the situations? I don't know, Junaid, or any of the other nephrologists, have you got any individual stories and experiences that you can share?
I mean, I can just comment. It was quite a few years ago. We were doing a talk at a mosque, and they had, I mean, I think I was speaking, and we had Professor Khan was speaking, and we had a Imam speaking, and there was a legal person as well. And in the end, one of the people in the audience got up and he said, it was in Afrikaans, I'll translate. He said, "Can't you just tell us what the right thing to do is? Like, don't, like, you know, just tell us if we must donate and we'll do it." So the public just wants guidance, you know, just tell us what the right answer is.
No, I mean, it's difficult when, as you say, there's difference of opinion, and I think that's why it's important for people to discuss it. I mean, as you say, from our perspectives as transplant physicians, the right answer that we appreciate may not be the same that some of the ulama agree to. And South Africa has been particularly difficult to get a overarching fatwa opinion from the ulama to say that this is what you should do. You know, I think they're very, very cagey about this issue, as you say, mostly Hanafi ulama. Any other opinions, Zubair, Zach?
Can I comment? Can I comment?
Yes. Shabir is an experienced pathologist, and I'm sure he's come across this question many times. Welcome, Shabir.
Okay, so just one particular, I think this was maybe a bit before Zunaid's time. There was an incident that I know of in Cape Town where a father was on a waiting list for a heart transplant, and his son then died of had a brain death. And the father was then asked, would you agree to donating the organs? And you can understand this father said, I need some time, but he did come back and said yes. So I think when it comes down to that personal level, that can be a learning experience. One, two, I in my first paper that I published, I approached every organization in South Africa, Muslim organization, in terms of to say what was their view. I think of the 15 or 20 that were there, I think maybe 2 or 3 agreed and said it was the desires to do that. The one that I won't mention who the author was said that if you take a heart from a person, if you take any organ from a person who has a beating heart, then you should be charged for homicide. I don't leave it to your imagination who said that. You probably will all realize what that is. But the bottom line is, I think there were times when I got a fatwa from the MJC in the early 90s. At that time, the MJC said they accept, they'll accept organ donation and organ acceptance, but they don't accept brain death. Just before Mufti Taha Karan passed away, we were addressing that issue. We had met twice, and then he took ill. In the impression I got that he was prepared to reverse the view of his father, the fatwa that his late father gave. He was prepared to reverse that. And also, I think generally it seems to me that in South Africa, the alims are not prepared to engage on this issue. If you look at, as Zunaid has outlined there, many parts of the world, Muslims, whether it's Shia or Sunni, they've all sat down and addressed the issue. I also attended a conference in Indonesia in about 95, 96. The general consensus there was it is acceptable at the end of the conference. But the Indo-Pak situation is completely different. And I think there's been a change of view. Zunaid may be able to correct me on that, where even Egypt is now saying no. At one stage, Al-Azhar said yes. So there is now the rest of the Arab world is acceptable. They say brain death is acceptable. It's not a problem. And I think Rafiq was also quite involved with a lot of it. So from a South African point of view, really, we need to sit down and engage. I mean, the Jamiat has to come on board. The NGC has to come on board. I tried very hard to get a conference going in Cape Town, but it seems, maybe I'm wrong, but the ulama don't seem to be well equipped enough to address the issue. So for them, it's rather, we don't want to go there. I think, Shoaib, you also have had some experience in this regard.
Okay. Yeah, I think there's we have quite a lot of difference of opinion on many things amongst our ulama in South Africa, and it's obviously it's a tricky situation in South Africa. There's a lot of fractured groups in different bodies, and you're sitting at a situation where you now have, we can't even make a decision on when the moon is visible, So I think we really have a difficult job here in South Africa. Our sort of Islamic unity is at sort of great threat. So I really think that as individual Muslims, you need to then have this conversation within your family, and then within the context of the ulama that you trust. And as Zunaid said, I think there's 0 Muslims donating at the moment. It's 0. So if we have this conversation, I think there'll be a percentage of Muslims that will donate, because there are ulama in support of it. There are people who are in support of it who can look at the different opinions and who will make up their own minds. And we know that Allah subhanahu wa ta'ala is all forgiven. And there is Islamic precedent that where there is difference of opinion, that there is some leeway for the individual to make to make their own decision. And I think that's going to have to be our approach in South Africa. I think it's very unlikely we're going to get a blanket opinion from the ulama, which says we may get a few isolated ulama giving opinions, and I'm not sure whether they'll be brave enough to do it, given the current discourse amongst our ulama in South Africa, which tends to be vitriolic and almost hateful. So I think we're really at a position where we're struggling with that.
If I interrupt you again, I think there's also a view that on controversial issues like this, there are some very good alims who have said yes, and some who have said no. And I think the opinion of one of the muftis when this was discussed was said that, well, that this has to be done at an individual level. The other thing I think we may suggest, we haven't done this for a long time, is maybe we need to engage in each province with the ulama so that we, I mean, for example, Zunaid and Rafiq know the ulama quite well. I know some of them. If we can engage them again, not in an open meeting, but in a closed meeting, like I said, Mufti Taha Quran was prepared to reverse what his father had said. I think that would be a worthwhile exercise in the Western Cape. I don't know what Rafiq and Zunaid would feel. It may be worthwhile looking at Natal, but I can almost assure you from the north and from the east of us, we're not going to get anybody who's going to agree to that. In the Western Cape, I can assure you, I know of at least 3 or 4 alims who will say, no, it's permissible. Some of them who said that then are still alive and would still agree. Should we look at this? Should we visit that issue?
So yeah, I think, I mean, there's lots of questions. One of the other questions which has come up, and it was posted before this talk, and somebody who couldn't attend to find out. So, obviously, organ procurement in brain dead donors is done without sort of full anesthetic. The patient is understood to be brain dead, and so the patient is not anesthetized in terms of pain. And there are some hadith which allude to the fact that the dead body feels pain, don't break the bone of a Muslim or somebody who has passed away and so forth and so on, that the mayat can hear what's going on. So, I mean, I think we need an open discussion. There's no actually, principled opposition to anesthetizing patients, even though, there may be an opinion that they don't feel anything. We could say, okay, it's fine for the Muslim community. That's a request. These patients will be anesthetized. We will do the standard anesthetic that we would do for somebody who is living so that they don't feel pain. So I think that's the type of individual approach that we need to look at in South Africa and amongst our community. We need to take these individual questions. We need to dissect them and look at what's permissible, what's possible, and then I mean the individual people must make their own mind. But you can't make this decision when you're in the grieving situation, when somebody has just had the trauma or the person is dying. This has to be something which is discussed in our community over time, and that people are able to make these decisions well ahead of time. Uncle Harun, I see you want to say something? Yeah.
Harun Tayyab, yeah?
Yeah.
Can I go ahead?
Oh, yes, please.
Alhamdulillah, Assalamu alaikum. I'm sorry, I was a bit late. I was late to attend, but anyway, all I want to say is that very little has changed since my experiences in nephrology from the 1970s up to date. First of all, just to inform you, I actually registered as a donor, and what I had to do also was to inform my family that at the time of your death, and if you are a donor that can be used, the family will be asked as to whether, in spite of the fact that you have registered as a donor, the family will be asked as to whether they are agreeable. And apparently, if they say no, then then you as a donor are not taken into full consideration. Their opinion or their request will be final. So that's one problem. So you need to discuss with your family, like I have discussed with my family, and inform them that, listen, I am a donor, and I hope that none of you will interfere and that will not refuse at the time if my body is or my organs are acceptable. That's point number one I want to raise. Secondly, like I said, things haven't changed from the 1970s. But the problems that we had in the initial years was, and most of the time is that, I can take a kidney, but you can't give a kidney. So that's one of the things that we have difficulty with, because when you return to Allah Ta'ala, He expects you to come back with both kidneys. He sent you down with 2. Why are you going back with 1? Are you the same person He sent down? The other problem is that, not only are we so confused about transplantation, but I've had several cases of people who've refused dialysis. And when I talk about patients who refuse dialysis, I'm talking about somebody very, very learned in the Islamic religion, and absolutely dogmatic with I met the circle of friends, all of whom are involved in the Islamic circle. And they were dogmatic that their imam will not accept dialysis because this is Allah's will, that it has been determined that he is to die in this particular state. So we even have a big problem in that respect. We don't even know whether we should be allowed to live or die. Should we accept the scientific treatment that is available? So there's so many problems. Now today, we've got radio stations that are basically every weekend, they're collecting funds. They're going on to major donation plans. These are the stations that we must now start using them. I think we need to get talks on a regular basis. If we're going to cause any mindset change, we must start now using social media, and we must use this. This is an opportunity. In the past, we didn't have all this. I think now that we've got the social media and we've got these television stations, radio stations, we should start. Of course, we have to negotiate with the ulama because they control the power at the present moment. But I think even without them, we still need to go and talk about these things ourselves as organizations. So that's my suggestion. Yeah.
Thanks for that.
Thank you.
Uncle Harun. Salim has put another comment that the concept of brain death, in my view, is problematic because of the active cardiopulmonary status. So maybe that looking at the comment of the concept of especially harvesting kidneys after cardiopulmonary arrest with the education of the religious establishment may alter opinion. So Sunil also pointed that out, that if we as institutions, as medical institutions, kit ourselves up and make the opportunity for donation after cardiac death possible, and that it may make it palatable for many more people to donate. And as Salim also says, as a simple test, and as it relates to myself first and many of us on this platform, how many of us are card-carrying donors? So established opinion and personal circumstances are driving forces of donating organs. So certainly, I think many people, I think one of the exercises about becoming an organ donor, and I did it myself too, just like Uncle Harun mentioned, is that it forces you to discuss it with your family. And to discuss the permissibility, to discuss it with your ulama, to think about it, to look through the literature. So I think that's one of the things within our community we can look at. People can then make independent decisions based on their own circle of advisors and their own family as to whether they would want to donate. But at least they will have thought about it well before that circumstance arises.
Sure.
Chair.
I just want to make a comment that after I spoke to my family and informed them that I'm a donor, they all accepted the fact that they will not interfere. And I then asked the next question, and I said, which one of you will also be a donor? And everybody was shut. So even within our own families, it's not only the outside world, even your own families, they're not educated enough. We haven't talked even to our own families about the situation. So I think we need to change within our own homes as well, the mentality. So just the point there. Yeah.
Yeah, Jazakallah for that. So I don't know if there are any other comments or questions. Yes.
Harun mentioned something about using the radio station. We did do that. That was also a long time ago. In fact, we had several doctors and we had one alim, and we teased him to say that all the questions are going to be for you. And lo and behold, 99% of all the callers who called in on the radio station had a question for the alim. So regardless of what we do and say, the Muslim community will take guidance on this from the alim. That's why I said they are paramount in this. If they don't address the issue and if they stay detached, nobody's going to listen to us because people will only accept guidance from the alim. So that's why I said we need to engage them first. If they say yes, and then as Renee said, it has to come from the member, and with time, and it's not going to be an event; it's going to be a process. It will not happen in our lifetime. And maybe the next generation of doctors will be able to convince people for them to donate organs. But I think it's a process that we have to constantly address, and we can start now. I think we need to readdress the issue and take it on from here. I don't know if people will agree with that.
Yeah, I think
now that Shoaib, now that Shabir is retired, maybe we can tell Shabir to go and do a course on alims, then it'll be easier.
Another comment. Are we allowed to donate organs to a kafir, a non-Muslim who might end up with your organs in the fire of Jahannam? Just a thought. So, I mean, obviously, this is the type of questions that we really need to, the serious questions and the important issues for people. And the ulama will need to address them, whether the reconstitution of the body in the year after is the same body. We know that that person is reconstituted in perfect condition, even if you've had your organs removed in the past, in the year after, if you've had an amputation, you won't be reconstituted with an amputation, in the year after. So I think these are questions which obviously the ulama will have to apply their minds to. I'm sure others have applied their minds to this in the past, so I think there are lots of aspects which are open for discussion, but the important message is that they need to be discussed. We're not even talking about it at the moment. We're just silent. So I think we've had a very good discussion, alhamdulillah. I think there's a lot of food for thought, and we had quite a lot of attendees, and I hope most people can take this forward in their communities. There's lots of fantastic information from Zach and Zahir about fasting in Ramadan and patients with chronic kidney disease and with transplantations. There's still a lot of questions to be answered, but I think the message that came through from all three talks is that you have to approach the individual in front of you with the knowledge that you have and with the particularly circumstances that the person has, and then make a decision, a shared decision between yourself and the individual as what's safe for them, what they can do, and from the perspective of donation, as Junaid said, what they're comfortable with doing, what they feel is permissible, and what they're able to do. But it's important to have these conversations well before the time. When it comes to fasting in Ramadan, well before Ramadan, to have these conversations with your patient, whether they have a transplant or chronic kidney disease or any other serious medical condition for that matter. And when it comes to donation, well before the time of your own death. We should be having conversations about our death with our family in many different aspects, whether it comes to inheritance and our bequests and our bequests and our passing on the next world, how we would like to be buried, and also the option about whether it would be possible for us to donate our organs, whether it's permissible and whether it would be desirable for us. So I thank every one of our attendees and of our guests for talking, and I wish you all well for the remainder of Ramadan. There are many auspicious nights coming up. We ask for prayers from everybody, and then we wish each and every one of you a wonderful Eid. So with that, I'm going to sign off. Assalamu alaikum wa rahmatullahi wa barakatuh, and jazakallah.
Okay, yeah, I'm glad I came to you. Otherwise, I would have missed the whole talk.
No.
So for future, basically,
You got to